talk of guest faculty talk of Dr. Rajesh R. Dr. Seema has joined our secretary, ex-secretary Dr. Subrato Mitra is there. Welcome, Dr. Subrato. You have to say a few words before Dr. Malaya Verma's vote of thanks because you are since morning and I can see you
Yeah,
are
yeah, I'm
considering
since.
Vibhuti Bhushan. They have to say a few words before vote of thanks. So Vibhuti is also there. Seema is there. Seema could not come because of the GTR fast. So please take up coordinators. Please take up Dr. Rajesh R. Dr. Rajesh, are you here?
Yes, ma'am. He is here. He is here.
Okay.
Dr. Rajesh, you can start your presentation.
No, have you done his introduction?
No.
Ma'am, we have already dealt. We have already introduced him, ma'am.
Okay, he's from RP Center, AIMS, New Delhi.
Yes, ma'am. Yes, ma'am.
And he has done his fellowship from
Shankara.
Sankara Netralaya. And he's the right hand of the most senior faculty of retina,
Dr. Mahesh P.
Dr.
Sangam.
Mahesh P. Sanmugam.
Yes, ma'am.
Okay, shall I start sharing my slide, ma'am?
Yes, please. Yes, please.
Sir, can you see my slides, sir?
Yes, it is visible and you're audible too.
Yeah. Thank you. Thank you, Dr. Bharti ma'am, for this opportunity. So I'll be presenting in one of the least, told about problem. So we were confronted upon a few patients who had an accelerated diabetic retinopathy, and we were fumbled upon what would be the probable cause. So since we started searching for these lesions, what might be the reasons for aggravating such conditions, we had a few of our own patients. I'll just go through the history of some of them. So when I looked into how would I divide these patients, based upon certain systemic factors, which comorbidities which the patient had, or the ocular features which I had presented with, along with diabetic retinopathy, and some masquerades, which since we are an oncology center, we do get some masquerades which can manifest as diabetic retinopathy. So these are the three broad classification on which we see patients who had previously had a very subtle amount of diabetic retinopathy, and they suddenly had some increased accelerated outgrowth. So getting one by one, so let us look into the hematologic dysplasia. So I'll just start with one of my patients, 61-year-old gentleman who had presented with us with a diminution of vision in the right eye for 20 days. He was a known diabetic and hypertensive with fair metabolic control. Not to mention his vision acuity was also quite okay. The right eye had 612 N6 and the left eye has about 66 N6. He has dyslipidemia also. He had received some amount of anti-VEGF elsewhere because the right eye had central involving diabetic macular edema. So this is what he presented with. You can see the color photos and the OCT. OCT shows cystoid macular edema in both the eyes, a little bit left more than the right. So what we decided, since he had already received anti-VEGF, we thought let us give him the benefit of Osidex since it was just introduced at that point of time. And we saw whether it might give some additional benefit as compared to anti-VEGF. This is about, we could see that about 10 to 20% of the reduction of CMT had occurred in the right eye as well as in the left eye also. So looking at this within the matter of 2 to 3 weeks, we felt that the patient might respond better, and we continued monitoring him. But at 4th week, we did had some amount of laser and followed him up. But for our dismay, both the eyes at around 4 to 6 weeks post focal laser started developing the edema. The edema had regained, and now it was much more than what it was to present with. So, I mean, the patient was most probably frustrated because he had already seen multiple doctors and it had presented to us. So he was lost for follow-up. Maybe again, he went for some amount of second opinion. And then he came back after 10 months later. And 10 months, it was even more dismayed. The vision acuity in the right eye had now deteriorated to 3/16 and 36. And he had some amount of cataract, maybe because of the Osidex, which we had given. And post that, in that 10 months, he had some other injections elsewhere. And the left eye was a bit more maintained. It had 612 with N8. So look at the amount of CMT in this patient. Right eye, it's completely ballooned up, as well as in the left eye also. And since the cataract had progressed in the right eye, that's why the vision was much worse. So we took a dive into the systemic examination. Systemic profile was very much within acceptable limits. What I mean by that, HbA1c and hypertension. But the one thing which was noticeable was his platelets. It was about 60,000. And then we diagnosed this patient as ITP with hypertension and moderate NPDR with status post multiple injection and laser. So ITP was the main cause of this recurrent edema, which was not readily getting cured or responding to the standard treatment, that is anti-VEGFs and Osidex. So the patient came back after all these investigations and the physician opinion. Now the platelet was 30,000, and you can see it is even more ballooned up. So only thing that we need, what we noted was when we look back into the history and all his investigation and OCT, and we correlated his blood examination, it was seen that whenever the macular edema fluctuated according to the platelet, so the platelet was less, the macular edema was more, and the hemorrhages were more. And when the platelets were better, the hemorrhages were, and the edema was much better. So we started the patient to go on with systemic steroid. We can see how once the ITP was under control with the systemic steroids, with 1,75,000 of the platelets, the edema was getting better without any intravitreal injections or any other intervention, ophthalmic intervention. So that's the one thing. So whenever we have a patient who has blood dysplasias, not only this, even in patients we have CML. So these patients also present with these cystoid macular edemas and hemorrhages, which may not be correlating with this systemic control of sugars and hypertension. The second well-known association with diabetic retinopathy is nephropathy, because diabetes do cause chronic renal disease also. So this is one of the classic patients where patient presents to us, we have treated, it was stable, quite stable, sugars are understable, but once the patient comes with the deteriorating renal parameters because of whatever the reason, we can see that the edema is progressing. So second of the causes in which there is an accelerated diabetic retinopathy changes despite the sugars being under control is if there's any worsening of the hypertension or nephropathy, we can definitely correlate with the worsening eye conditions also. Third is if a patient has undergone a cataract surgery, we know that if a patient has a center involving diabetic macular edema and the patient undergoes a cataract surgery, there's definitely progression of the involvement and further deterioration of the edema status post cataract surgery. Even to that extent that patients who were well treated and were completely stable at the time of cataract surgery, 20% of these patients who had resolved diabetic macular edema post cataract surgery can develop. But in this patient, you can see that the minimal amount of CME which was there post cataract surgery is developed into what we call as the cystoid macular edema and some amount of NSD also. So these patients are usual form of treatment of IVTA or DEX implant can definitely resolve the macular edema and keep them stable. Patient who has hypertension do know have retinal vein occlusions, either TRVOs or BRVOs, even to the extent of CRVOs also. So a patient who has diabetic retinopathy who suddenly develops increased macular edema or neurosensory detachment, we need to look closely because certain small tributary retinal vein occlusions can cause quite exacerbation of the macular edema, which may not be completely stable or mainly responding to the regular anti-VEGF that we give to these patients. Coexisting macroenzymes. So what we look at is the AV crossings where some of these patients do develop macroenzymes, and macroenzymes can bleed at all levels, whether it's epiretinal or preretinal or even to the extent subretinal or intraretinal. So any of these levels, the hemorrhage might proceed and cause concomitant macular edema. So a patient who is quite stable, what we trivially look at as mini or micro or mini aneurysms might enlarge to macroenzymes, and that can cause bleeding and development of macular edema. So we need to keep a close follow-up of these patients. If such a thing is noted, then we can laser, or most of them they self-convolute, but if we laser, the edema also regresses for a period of time. So another concept which we came about a few years back is when most of these diabetic macular edema patients who have some microaneurysms are treated with anti-VEGF or DEX implant, they do respond beautifully. But what we looked at is some patients, despite the injection, you can see this is all the upper OCTs are pre-injection and the lower bottom OCTs are the post-injection various, whether it's anti-VEGF or DEX implant. You can see the response is very, very minimal, marginal, not even 10% of the initial CMT that we look at. So when we look very closely, what we could see is enlarge it. We had these aneurysms which are a little bit more than the microaneurysms which are typically noted in diabetic retinopathy. So this we termed at that point of a time as mini aneurysms. These time, I mean, over a period of time, they have been labeled by various groups in various terminologies, telcaps, or PEVAX and other things. Nomenclature has been given. So telcaps is what has been noted recently. So these, what we call a little bit more than microorganisms, do not respond very, like any other usual mini-organisms or patient with diabetic retinopathy. These patients do respond beautifully to laser. So if at all we note these patients, which are very clinically seen as well as in OCT can be picked up, and once we do laser, so they resolve very wonderfully. The edema goes down. Rather than only relying on anti-VEGFs or dexamethasone implants or tripod, we need to laser these patients. So focal laser is always added armamentarium, which we should never forget it. So some patients do have what we call as a premacular bursa. So the PVD is not there. There is an empty space between the posterior hyaloid and the macula. So these patients are known to not to respond to the regular treatment. That is, once we give anti-VEGF, the reason behind is these empty bursa spaces prevent or does not allow the pharmacological agent to reach the retinal surface and thereby causing the resistance of edema. So if such a thing is noted and the patient is not responding to, then definitely would suggest to pharmacological vitrolysis or like Jetria, or we can go ahead with the vitrectomy in such conditions. So that allows a single space of the vitreous cavity, and whatever pharmacological agents that we give can respond beautifully to these patients. So this is the premacular bursa which I have documented in the OCT overview. So this is anti-VEGF which was given, and this is 1 week post anti-VEGF. The response is
Excuse me, Dr. Rajesh, would you like to sum up, just wrap up?
Yes, ma'am, that's it. Just another 2 more cases. So whenever we give anti-VEGF, we think about the patient to respond beautifully, but you can see in some patients, it doesn't respond like that. It worsens. In fact, the macular ischemia increases post in these patients with central involving macular edema. The reasons unknown, but the basic reason behind is the increase in the macular ischemic nature. Diabetic papillopathy is another added features in some patients who develop papillopathy because of hypertensive NAI1 and other conditions might lead on to a sudden progression of the retinopathy and loss of vision, which doesn't correlate very well to the systemic control. So this is one of such conditions. Any of the radiation retinopathy. So a patient who has diabetic retinopathy, who has melanoma or anything, this is a patient who had been melanoma, who had been treated with brachytherapy, and that causes an additional radiation retinopathy, which might mimic like diabetic retinopathy and causes visual loss. So it may not be related to the systemic nature. So CML, that's what I was talking to you about. Collagen vascular disease is another cause. You can see the amount of progression the patient had presentation, and this is a month later, he had developed a complete detachment. So this is immediately post-operative when the patient settled with under oil and the vision was retained. So in summary, background clinical information is very important, not just the status of HbA1c and hypertension. We need to access all his investigation, fundus images, FFA, whatever that is available with us. We should not miss anything. Even if we don't know anything, we need to keep it in, and check and keep looking back. What was the reason? And we may end up identifying a new finding with these pictures maybe later, but that might be enhancing knowledge for the future generation. Thank you.
Thank you, Dr. Rajesh. So because we are going too late, we'll be proceeding for the next session. It is on case presentation. It's for PG students. I'd like to just re-announce once again. It's a 6 minutes. Please stick to 6 minutes. It's a hard stop. And only one question. I will request all the judges to just ask one question to every candidate. So now the session coordinator.
No. One just one question. ऐसे रखो. One just one question.
Okay, ma'am. So the session coordinators are Dr. Sophia Ahmad, Dr. Reena Singh, Dr. Seema Kumari, Dr. Ashima Tigga, Dr. Pritish Pranoy. The esteemed judges with us, Dr. Sweta Walia, Dr. Firuz PN, Dr. Deves Kumawat, Dr. Piyush Bansal. The chairpersons with us, Dr. Sunil Kumar, Dr. Rahul Prasad, Dr. Abhishek Onkar, Dr. Poonam Singh, Dr. Bibhuti Kashyap, Dr. Tanisha Oza, Dr. Nidhi Gadkari Kashyap, and myself. So we are going ahead without any delay to our next PG students. Dr. Mayank Saran, are you available?
Yes, ma'am.
Sure, perfect. So, Dr. Mayank Saran, it's your time. Please start your screen share and please go ahead. Yeah, your time starts now.
Please start your slide, Mayank, Dr. Mayank.
I request everyone, please. Yeah, the next presentation is from Dr. Anvita Sweta Kachap. Please get ready. So, Dr. Mayank, your time starts now.
So the slide is visible to everyone.
Yeah, it is visible. You proceed ahead.
Good morning, sir, ma'am. The topic for my presentation is surgically induced endothelial cell dysfunction and corneal decompensation. So basically in this condition, there is endothelial cell loss, which might be due to pre-existing any corneal disease like dystrophy, or it can also be surgically induced, which leads to further stromal edema or epithelial edema. So normal anatomically, the corneal endothelium is a single layer of non-regenerative polygonal cells, and most of them are hexagonal in shape. But the main point is that the influx of fluid into the stromal layer is being prevented by some like barrier, which have like barrier function of endothelium, or there are some active pump mechanism like sodium, potassium, ATPase pump, bicarbonate, and chloride transporters, and some like carbonic anhydrase enzyme, which act as a pump out mechanism, which pumps the excess fluid which is present in the stromal layer back into the aqueous humor. So the pathophysiology for this condition is that whether the patient is having any corneal dystrophy or not, but during the surgery, whenever there is an endothelial injury, it leads to the break in the that endothelial barrier, as well as there is inefficient endothelial pump, due to which the aqueous humor or the fluid it moves into the corneal layers, leading to stromal edema, and later on, if it progresses further, leads to epithelial edema. And that chronic persistent cases of those epithelial edema leads to bulla formation, which is referred as bullous keratopathy. So for the risk factors, if we are like appointing any patient for cataract surgery, we need to rule out any endothelial dystrophy, mainly Fuchs endothelial dystrophy, because there is already deficient endothelial cells, or the patient is diabetic or having raised IOP. During surgery, we need to focus on if there is we are using like high mechanical energy in phacoemulsification, or there is surgical trauma by seeing some instruments, or while placing the IOL, one of the haptics might erode or damage the endothelial layer, or the direction of the irrigating solution towards the endothelial layer, or there is some detained lens fragments in the AC. Whereas in the post-op, if there is flat AC, so it leads to the contact between the iris and the endothelial layer, or there is vitreous in the AC, raised post-op IOP, or surgeon has put an ACR, again where haptic will erode the endothelial layer, or the patient has undergone into toxic anterior segment syndrome, where due to unsterilized instruments or there's preservative-based medicine or solution are being used. So clinically, patient will come with blurring of vision or glare, which is worsened at the morning because of that non-evaporative effect during the nighttime, or the patient may complain of pain, which will be due to the ruptured bulla, in which there is exposure of the nerve fibers. Whereas in sign, we'll see corneal haze due to that corneal edema. In severe cases, there will be epithelial edema leading to bullous keratopathy. And if there is improper healing of that endothelial layer, it leads to permanent decompensation. Then that patient is need to go for keratoplasty. So for the treatment part, if there is mild or moderate stromal edema is present, so we can give or advise topical hypertonic drops during the daytime and ointment at the bedtime. Topical corticosteroids can be given to control the inflammation, and if there is raised post-op IOP, so we need to control that also. the patient has come with ruptured bullous. So we need to like apply bandage contact lens to elevate the pain, or like we have done like anterior stromal puncture of that unruptured bullous. So again, we need to apply like simultaneous BCL application should be done. Whereas for the surgical part, if during the operation we have seen that there is descemet membrane detachment, so in that case we need to go for descemetopexy, where we just influx or we'll put air bubble or some other gases can we put, so that it creates a tamponade effect in the AC, and it puts the descemet membrane back in contact or in proper position with the posterior surface of the cornea. If like we have doing OT of a patient who has also fuchs endothelial dystrophy, so in those cases we also need to do like endothelial keratoplasty. Along with that, there is like cataract removal and IOL is being implanted. So that's a triple procedure surgery. In endothelial
1 minute more.
keratoplasty, in
1 minute
endothelial
more.
yes, ma'am. In endothelial keratoplasty, we have two techniques, either DSEC or DMAC, in which DMAC has better visual outcomes due to because we are only transplanting the endothelial layer as well as the descemet layer. And if there is a severe condition of the patient and there is like marked scarring or vascularization is present, then we need to go for penetrating keratoplasty. For preventive measures, it should be done like during surgery. Careful handling of the instrument should be done. Use of viscoelastic material should be done. And if the patient is having pre-existing corneal disease, so we need to manage that patient accordingly. Thank you.
Thank you, Mayank. You are on time. So, judges, would you like to ask any questions to Mayank?
Hello, Dr. Mayank.
Yes, good morning.
Good morning.
Good afternoon.
So, what type of keratoplasty has the maximum rate of rejection, the penetrating one or the lamellar keratoplasty?
The penetrating one.
Why?
Because mostly, ma'am, the rejection usually starts due to that. If there is endothelial rejection, is most commonly is you are responsible for that penetrating rejection.
Okay. Thank you.
Any other question from judges? Okay, we will be moving to the next candidate. Dr. Anvita Sweta, are you ready? The next one, please get ready, Dr. Pragyan Chauhan. Dr. Anvita, are you ready?
Yes, ma'am, I'm ready. Am I
Please share your screen. Please share your
Hello?
screen.
Yes, ma'am.
Yeah, go on.
You are audible. Please share. Your time starts now.
Dr. Anvita,